presentation with the basic cardiac anatomy relevant to the conductive system. We all know that the conductive system of the heart is formed of a specialized cardiac myocytes that has a distinct electrophysiological and histologic properties, and it's responsible for initiation and propagation of electrical impulses to the functioning myocardium. The main components of the cardiac, can you see my mouse, Alfie?
Yes, Prof. Rania.
Okay,
yes, we can see you now.
Okay, the main components of the cardiac conductive system, as we all know, the SC node, the AV conduction axis that we are going to talk about in detail today in our talk, consists of the compact AV node, the His bundle, or also it's called the penetrating bundle, and the bundle branches, right bundle and left bundle, and the Purkinje network. And the precise knowledge of the location and the anatomy of this AV conduction axis is very important and of paramount importance to gain a successful conductive system pacing procedure, whether are you going to implant a His bundle pacing or a left bundle area pacing. We'll start out our anatomical description by the first component of the AV conduction axis, which is the compact AV node or the AV node. And when we talk about the AV node, it's mandatory to talk about a very important anatomical landmark. All the interventional electrophysiologists know about it. It's the triangle of Koch, and it's related to the anatomy of the compact AV node. We all know that the triangle of Koch is a hypothetical triangle found in the floor of the right atrium, as we can see here in this heart specimen that is open, showing the right atrium and the Turcos valve. And we can see that the triangle of Koch has an anterior boundary of the attachment of the septal leaflet of the Turcos valve, as we can see here. The posterior boundary is the fibrous extension of the Eustachian ridge and the Eustachian valve, known as the tendon of Todaro. The base of this triangle is formed by the coronary sinus ostium and the septal part, the septal myocardium, atrial myocardium anterior to the coronary sinus ostium. This is where we usually ablate the slow pathway, and the apex of this triangle is very important. It's formed of the membranous septum, okay? And this is where in the majority of patients, the His bundle penetrates into the central fibrous body here. Okay, so so the compact AV node is usually located, it's a subendocardial structure, and is majority or 3/4 of the patients is located near the apex of this triangle, as we can see here in this diagram. It's located near the apex, as we can see here in this diagram. It's located close to the apex of this triangle or close to the membranous septum. But for 1/4 of the patient, this is very important, the compact AV node can have an inferior position in the Koch triangle close to the coronary sinus ostium. Okay, so in majority of patients, it's close to the apex of the Koch triangle, but in 1/4 of the patient, it can assume an inferior position closer to the coronary sinus ostium. And there's a variability in the diameter or the dimensions of the AV node, as we can see in a lot of morphological studies and anatomical study showed. And the location of the compact AV node within the triangle of Koch, as I showed, is variable. The AV node has a similar extensive autonomic innervation to the SC node. It has an extensive autonomic innervation. Okay. When we talk about the His bundle is the distal continuation of the compact AV node. Okay, it's, as we can see here in this heart specimen, it's the distal continuation of the compact AV node, and it connects the AV node to bundle branches. And the compact AV node ramifies or transitions into the penetrating His bundle that penetrates the membranous septum near the apex of the Koch triangle or the central fibrous body, okay, near the apex of the Koch triangle. And if we look at this heart specimen, we have two different heart specimens with different position of the compact AV node. one at a superior position near the apex of the Koch triangle, and another inferior position near the floor of the Koch triangle. And we have these three lines are three sections taken at this hard specimen with histological staining and showing the histology of the compact
Rania, excuse me, can you use the cursor? Can you use the cursor?
I'm using the cursor now, yes.
Is it working? Okay. Can you move it so that we can see if it's working?
Yes, I'm moving. Can you see it?
You don't see it, Rania.
You don't see it, so I'll try to use the
other cursor of the Zoom.
Okay, where is it?
Yeah.
Pointer options, this one, visible?
Yeah.
Okay.
Yeah.
Where is it?
Move it, please. Ah, yes, now it is moving. Yeah.
Can you see it now? I want to use the red cursor, but I cannot find it.
Yes, let's use the red one.
Where's the red one? Alfie, can you tell me where's the red one? Where can I find the red one?
Ali?
How can I find the red one? In more.
Use this arrow again, Rania.
Okay, I'm using it.
Ah, yes, it is shown. Okay, good. Continue.
Okay. Let me go back. Let me go back. It doesn't go back, sorry. Okay, previous. Okay, here. Can you see this now, the cursor? Can you see it, Dr. Mervat?
Move it, please.
I'm moving it. Can you see it? No, you can't see it. Okay.
No problem,
Actually, we can see it, Prof. Mervat, we can see it, but because sometimes when it is on a black item and it's black, so we cannot
move
see
it on the writing on the graph.
Can you tell me where's the red cursor?
Yeah, there is a laser pointer, but I think we have to go to a presenter view. But because everything is working, so
okay, it can't be complicated. Can you see my cursor now? Everyone, can you see my cursor now? Okay.
For me, I can see it. Yeah.
I can see
now we're going to talk about the histological features of the compact AV node of the Hess bundle and how it's differentiated from the functional myocardium. This is a hard specimen showing the compact AV node in a superior position and another hard specimen showing the compact AV node in an inferior position with 3 levels of histological sections. These are the 3 green lines here and here. And these are the 3 histological specimens. We can appreciate in this histological specimen, this is the right atrium, and this is the interventricular septum, and this is the blue one, the blue colored structure is the central fibrous body where the His bundle penetrates. We at the first section, this is the first section, A1 section, at the level of the compact AV node in both sections, this one and this one. We can appreciate that histologically the cells of the compact AV node is different from the functioning atrial myocardial cells. It's totally different in shape and in histological structure, and is separated from the atrial myocardium by a transitional cells which are not abandoned cells, and with abandoned connective tissue, there is separation between the compact AV node and the atrial tissue, but there's no fibrous band around the compact AV node. And in the second level, this is the ramification of the compact AV node and the start of the penetrating bundle, which is the Hyde bundle. And we can see here first, in the first section, we can appreciate that the AV node is a subendocardial structure and atrial structure. Okay, and then the start of the origin of the penetrating bundle or the His bundle from the AV node. Also, we can appreciate the histological difference. The cells of the His bundle, as we can see in this section and in this section, are usually Purkinje type cells, different from the cells of the compact AV node, and they have a longitudinal orientation and separated by collagenous septi. The Hess bundle in the third section we can see is completely encased by the central fibrous body. So it's encapsulated by fibrous tissue all around the Hess bundle, okay? as we can see in this section and in this section. So, and it's usually, it's an, it penetrates the membranous septum and the central fibrous body and emerges from the other side into the membranous septum, the other side into the ventricular side. There is another important structure we have to know about, which is the inferior pyramidal space. This inferior pyramidal space, this is an extracardiac space. We can see it here in the histological specimen here, and here in this anatomic specimen. The inferior pyramidal space is an extracardiac structure sandwiched between the right atrium and the interventricular septum, and is formed of fibroconductive tissue, and it houses a lot of important structures like the AV node. We said the AV node is a subendocardial structure, and also housing the AV nodal artery and other important structures. There are three anatomical components of the His bundle. The penetrating bundle of His that we can see here penetrates the membranous septum here and here, and here we can say it encased inside the central fibrous body. The non-branching portion that runs on the crest, and we'll see it in the next slides, the non-branching portion, the part that emerges on the other side, on the left side of the membranous septum, and runs on the crest of the muscular interventricular septum, and it usually ranges in length 1 to 3 millimeter, and the branching portion that closely related to the aortic ring, as we are going to see in the next slides. As we said before, there is a variability in the anatomy of the compact AV node. Also, there's variability in the location of the His bundle, and this is very important. There's a relative change or variability in the position of the His bundle in relation to the triangle of Koch. If we can see here in this, the penetrating bundle here in this, and it's related to the position of the compact AV node. If you have a superiorly located compact AV node, you'll have the penetrating His bundle superior in position and near the apex of the Koch triangle. But if you have an inferior position of the compact AV node, you'll have an inferior position of the penetrating bundle till it penetrates the membranous septum, and thus this usually explains why in some patients, when we ablate the AV nodal entrant tachycardia, we have a lower position of the His bundle recording, or we have a wide range of recording of the His bundle from lower down in the Koch triangle up to the apex of the Koch triangle. This is the first thing. And usually it assumes a superior position in about 60% of the patients, but in 40% of the patients, it assumes an inferior position. Also, in relation to the hinge point of the tricuspid annulus, the His bundle has a variable position. If we look at this histological, section in the heart specimen, this is the right atrium or the atrial wall, and this is the blue one is the blue color is the central fibrous body, and this is the interventricular or the muscular interventricular septum. This is the membranous septum, and this is the hinge point of the septal leaflet, as we can see here in this 3 specimen. This is the hinge point of the septal leaflet. In more than 50% of the patients, His bundle is located or penetrates the central fibrous body or the membranous septum away from the hinge point of the septal leaflet, close in an atrial position, distal to the distant away from the hinge point of the septal leaflet. So we cannot use in some of the patients, we cannot use the hinge point of the septal leaflet as a marker of the His bundle recording. We have to record the His bundle. And in about 30%, it's located just at the hinge point of the septal leaflet. And in about 15% of the patient, the His bundle is located below the hinge point of the septal leaflet of the tricuspid valve in muscular interventricular septum. So we have quite variability in the location of the His bundle, as well as we have a variability in the location of the compact AV node. When we come to talk about the bundle branches, before talking about the bundle branches, we have to talk about the membranous septum. We all know that the interventricular septum has a membranous part and a muscular part, as we can see here. This is the muscular interventricular septum, as we can see from, this is the heart specimen from the left side, cut longitudinally, seen from the left side, and we can see that there is a muscular interventricular septum and a membranous interventricular septum, the illuminated part. But this membranous ventricular septum is very important for the location of the conductive system. It plays an important role for the location of the conductive system. It's further subdivided by the attachment of the tricuspid valve, as we see here in this heart specimen. It's divided into an atrioventricular part and an interventricular part. The atrioventricular part, from its name, is located in the atrium, and it separates the right atrium from the left ventricle, okay? And this is the part that is located at the apex of the Koch triangle, and that is penetrated by the His bundle. And whenever we have a catheter, quadripolar catheter in this position, in the majority, or more than 50 or 60% of the patient, we can record the His bundle recording. And the other part of the membranous septum is the interventricular membranous septum that is below the tricuspid valve, and it separates the right ventricle from the left ventricle, and this where the His bundle emerges from the central fibrous body, and this is as the non-branching part of the His bundle, and it's as we can see the membranous septum, this part of the membranous septum is in close relation with the mitral valve ring and the aortic ring, especially the right coronary cusp and the non-coronary cusp. So there are two positions where you can record a His bundle recording. The part, the atrial membranous septum, or the atrioventricular membranous septum at the apex of the Koch triangle, and also you can record a His recording, and that now you're recording the non-branching His bundle recording just below the junction between the right coronary cusp and the non-coronary cusp at the interventricular membranous septum, and then at the crest of the interventricular septum, the left bundle emerges and starts to, this is the left bundle, the trunk of the left bundle, and then gives rise to its fascicles. And the left bundle, as I said before, it arises inferior to the membranous septum, below the non-coronary cusp and the right coronary cusp, and it's it assumes a subendocardial position. It lies subendocardially on the left side of the interventricular septum and branches out in the majority of literature into trifascicular manner. As we can see here in this heart specimen, this is very important. This is the right coronary cusp, non-coronary cusp, and this white thing is the membranous septum, where the His bundle can be recorded here and emerges from here and gives rise to the left bundle trunk. And in this heart specimen, we can see that the left bundle is a broad, wide structure, but there also variation in the width and the length of the left bundle from one heart to the other. Okay, and it's a subendocardial structure. This is blue. The blue colored structures are the left bundle with its fascicles, and it branches out into a left anterior fascicle that is usually a long and thin cord-like structure, passes to the left anterior papillary muscle, and it ramifies into a network of Purkinje fibers at the base of the left anterior papillary muscle, and then branches out to the left posterior fascicle that goes to the left posterior papillary muscle, and also gives a Purkinje potential network at the base of this fascicle. Some authors say that there is a septal fascicle, and other authors say that we only have two fascicles, but the majority of researchers say that we have three fascicles. So we have a septal fascicle that supplies the mid-septal area, and this septal fascicle usually arises from the left main trunk of the left bundle, or sometimes it arises from the left anterior fascicle or the left posterior fascicle, or a network of bundles between the left anterior fascicle and the left posterior fascicle and gives rise to the septal fascicle. So there's quite big variation in the anatomy of the left bundle. But what we can notice here from the previous histological specimens and this morphological specimens, that the area of the His bundle is a very narrow targeted area, and it's encased or encapsulated by a fibrous tissue all around it, while the left bundle and the left bundle branches is a large area, subendocardial large area that you can target anywhere you like. You can target the left bundle trunk, you can target any of the fascicles for left bundle area pacing. That's why left bundle area pacing is quite easier in achievement than His bundle pacing. And here we can see the histological and macroscopic characteristics of Purkinje fibers. This is a histological specimen of the Purkinje fibers. These where the red arrows are, this is the Purkinje fibers, and this red muscle fibers are the ventricular myocardial cells or the functional cells. And we can see that the Purkinje fibers are in close relation with the functional myocardium. There is almost no separation, only just some thin area of connective tissue. And here, this is the macroscopic image of the Purkinje potential in close relation to the functioning myocardial cells. So the most impressive feature of left bundle anatomy was the marked variability between individuals. As I said before, the origin of the left bundle is broad in some people and narrow in some people. There's variation. It ranges either from 1 millimeter to 14 millimeter in width, and is significantly influenced by the anatomical relationship of the His bundle to the interventricular septum. The size, number, and location and configuration and distribution of the left bundle subdivisions or fascicle is still a matter of active debate. And some researchers consider left bundle is exclusively bifascicular, while others say that there is a septal fascicle. Okay? And this is my final, I think this is my final slide. And this is a dissected heart specimen put in a simulated RA view to appreciate the AV conductive system. Here we can see this is the compact AV node, the penetrating bundle where it emerges, and here with the compact AV node has an inferior position in the Koch triangle, and the penetrating His bundle penetrates the membranous septum at the apex of the Koch triangle and gives rise to a right bundle, and the red dotted line represents the His bundle trunk and the 3 fascicles on the left side of the interventricular septum. And here are demarcation of these structures in fluoro image in our view. The quadripolar catheter demarks the His bundle, and here all of these area are your target for left bundle area pacing, while only this area is your target for His bundle pacing. So in conclusion, in light of revised interest in the conductive system pacing, understanding the precise anatomy and histology of cardiac conductive system is crucial for improving success rate and clinical outcomes. In narrow target zone and variable position and the dense fibrous tissue surrounding the His bundle explains the technically challenging procedure and high thresholds at implant or delayed rise in thresholds. By contrast, the wide target zone and dense muscular tissue surrounding the left bundle and its fascicle, particularly left posterior fascicle, explain the relatively easy procedure with stable and low threshold in left bundle area pacing. Thank you, and I hope I was easy to explain.
Thank you very much, Professor Rania.